wanted to pursue. I had strongly considered OBGYN, and one of the reasons that I chose family medicine was that I wanted to deliver babies, and I had the opportunity to deliver lots and lots of babies. And I really loved that role as a family doc. And I saw my role as a family doc to be assisting a family in a transition from intrauterine life to extrauterine life. A transition that was going to happen whether I was there or not. Babies come out almost all the time. And they come out safely most of the time. But my primary role there was to keep this as safe as possible for the mother and the baby, and to make it as painless as possible. And I loved delivering babies. I delivered my last baby 13 years ago. It was my grandson, a great way to end your OB career. And he and I have a very special relationship at this point. And after delivering that baby and becoming the chair of family medicine and not doing some of those things that I really, really enjoyed doing as a doc, I didn't think anything would ever replace the OB yin, the OB desire that I had until I got introduced to hospice medicine. People are going to die whether I'm there or not. It's a natural process. It's a transition that a family's going through. And I get to be there to make that as safe and as painless for this family as it can be. And so what we want to talk about this morning is how do we best talk to our families about death and dying. And our learning objectives are pretty simple. I'd like for you all to consider with me some of the barriers that make it hard for us to talk to our families about death and dying. And I would like for you to be really introspective during that time, if you will, and think about what are the things in your heart, what are the things in your mind that make this especially difficult for you, because it is difficult. The second thing I'd like for us to come away with, got to get the right buttons, is that you can learn at least a couple of 3 communication tools that you will be able to use the very next time you're called upon to give bad news. And finally, I hope that you'll learn some ways of communicating not only the truth about death and dying, but your care, your concern, your love for this fellow human being that you're getting ready to talk to. But before we get into the meat of this, let me switch over here and let me let Moody Blues say it for me. Say it with love. We had a hard time downloading this morning. Say it with love. I've been thinking the way people do about the things that matter to me and you. I've decided to do what I can to find the kind of man I really am. A lot of introspection involved in this business. I can see the world from here. Sometimes it feels that way. And sometimes I don't like being there. It makes me just want to disappear. Back to nature, that's where we belong. With just one truth, I found you can't go wrong. Wherever you go, whatever you do, whatever you say it, say it, say it. Say it with love. If you're not into Moody Blues, maybe you'll go to some ancient literature. The Apostle Paul in the New Testament, in his letter to the Ephesians, says, but speaking the truth in love, that's the way we grow up and be like Christ. And the head of the church, who was said to be full of grace and full of truth, speaking the truth in love. We're a small enough group that I'd like to get some audience participation if I could. Think about the word candor for just a minute. And can you give me a 1 or 2 word phrase that would describe candor from your point of view? What's candor? Truth. That's a big part of candor. What else comes to your mind? Frankness. Any other words? Full exposure. Okay. I like that, and I'm going to come back to it in just a minute. Anything else? If you go to Webster, unreserved, honest, sincere expression. Kindliness is a part of candor. Freedom from malice and prejudice. If I'm going to be candid with you, it's never with the idea that I want to hurt you or that I want to put you down. I want to make you feel bad. It's without prejudice. It's without any malice. Some synonyms, one I don't like very much is bluntness, because it just sounds so blunt, I guess. Forthrightness, I think somebody said that one. Open-heartedness, I think that's that total exposure thing that you're talking about. And you know what? If this is going to work, it's got to be a two-way street. The only way that I can really get my patients to open their hearts to me is if I am willing to open my heart to them. Open-heartedness. You know, we talk a lot about the doctor-patient relationship. But even more basic than that doctor-patient relationship is my relationship to you as a fellow human being. Somebody made in the image of God. They're sitting across from me. And I bring all of me into that room. Open-heartedness is a very important part of candor. So speaking the truth in love is one of the ways that we can talk about candor. So what's the essence of what it is we want to say to people who have a terminal illness? You're going to die from this illness. You may die very soon. But we want to do everything we can to help you live well until that time comes. That's the essence of the message that we need to be saying to our patients. Now, do we always do that well? The answer is no. Okay? This is from the Candor data. There were almost 1,200 patients in this study. And what this study did was it took a group of people with stage 4 lung and colon cancer. And they are patients who had their diagnosis, who were going to be on chemotherapy or who were already on chemotherapy for stage 4 lung cancer. And what they asked these folks was it made clear to you when you began the chemotherapy that this was not something that was going to end up in a cure? Now, it's not talking about prolongation of life, it's talking specifically about the word cure. And a large percentage of these patients, 69%, of the patients with metastatic lung cancer and 81% of the patients with metastatic colon cancer said they were never told that the chemotherapy was not going to provide a cure. Okay? Now, communication is always a two-way street. And one of the things we're going to talk about in a few minutes is denial. So I'm not sure what these numbers mean, except we need to keep repeating, and tell the story over and over and over again so that people understand the truth about what's going on. Now, there's an interesting sidebar to this study. And the sidebar to this study that I find interesting is that they also ask these patients to rank on a Likert scale how much they liked their oncologist who was managing their disease and who was talking to them. And at this stage in their lives, the ones that they liked the most were the ones who tended not to press the idea of this not being a cure. Okay? So the docs who say, honey, I'm going to take care of you, don't you worry, everything's going to be all right, they were better liked than the docs who were more forthright. Now, I don't know what forthrightness looked like with all these, but they liked them better. Now, the thing that we don't know about this group of patients is we don't know what their attitudes toward their oncologist or other doctors were after their disease progressed. So what do patients tell us? Patients tell us almost always that they want direct, truthful information. And if you're ever in doubt about that, then you should ask. I can only remember one patient in the last 5 years over at the hospice house where I asked, what do you want to know about what's going on? And she says, don't talk to me about anything. You talk to my husband, and he will tell me what I need to know. Now, I never knew what that husband ended up telling her, but that's how she wanted things to go. We need to respect that when our patients tell us that. Patients are very, very good at finding effective ways of coping with bad news. Many of us have as one of our barriers that we don't want to be the one responsible for destroying hope. Hope's bigger than this, folks. And so that's something we really, most of the time, don't need to worry about. And one of the things they tell us is that physician empathy and honesty improves trust, provides for the opportunity to make more clear goals of treatment and better decision making. Not being candid, therefore, results in half-truths, misinformation, makes for lack of clarity about goal setting that's consistent with what this patient and their family wants. And worse than no hope is false hope. Because it is so disappointing when we get down to the end and we find that we've been misled in some way. So what are some of the barriers that make it difficult for us to have this conversation? Why is it my stomach churns when I get ready to have this conversation? I don't want to be the bad guy. After all, they've got a primary care physician. Why don't they tell them this stuff? That's what primary care physicians are for. Or the primary care physician say, you know, I don't know as much about this chemotherapy and the prognosis and that sort of thing. It's somebody else's responsibility to tell them this bad news. I don't want to be the bad guy in this person's life. I want to be their encourager. Families don't always want the patient to hear the truth. Have you run into that? You know, some of you have been over to the hospice house. Some of you have not. But if you walk into the hospital, into one of the rooms at the hospice house, there's a short little hallway that you walk in before you get into the main room. And it's a spacious room by hospital standards. And sometimes there's as many as 15 or 20 people in that room around the bed. And so you open the door after knocking. The room is dark. It's full of people. They are whispering. And there's a sentinel at the door who grabs my coat or grabs my shirt and says, "Don't say cancer. They don't know. Don't tell them they're dying. They don't know." So sometimes families don't want their patients, their family members to know. And maybe there'll be time at the end if you're curious about how I handle that, but we'll move on. There's always the hope that maybe the next treatment's going to work. And you know, there's one more thing we could try. Most of the time we try the things that we think are most apt to work first. And so the odds are going down usually as we go down the list. But maybe the next one will work. Now, how many of you have had lots of training in helping your patients go through the dying process? Not many of us have. But when you go to medical school, when you do a residency, when you do a fellowship, you're training to save lives. That's the focus. I want to cure disease. And it is a good focus. I don't want to in any way come across as sounding like I don't think that's important. I think it's terribly important. But you know how it is in July and August when the new third-year clerks are on the floor? You know, and they'll be walking down the hallway and there comes one of their buddies. Did you save any lives today? Did you cure any disease today? You know, that's what we want. And you remember it. I see the smiles. They say, yeah, I remember when that happened. We're trained to fight. We're trained to heal. We see death as the enemy, and we're out there to conquer the enemy. And there are some docs who have the attitude, I never give up on my patients. Not until their hearts won't stop beating, it won't continue to beat while they're on the ventilator. I never give up. I'm going to try to the very end. And here's an interesting one that keeps us from being candid sometimes, and that is, I feel so guilty. And I think the primary care docs probably experience this more maybe than others. Boy, if I had just ordered that colonoscopy 9 months earlier, maybe those cells wouldn't have gotten to the liver. Maybe we could have saved this patient's life. I don't want to talk about this. So there are a lot of barriers that keep us from talking. Some more. I don't handle crying very well. Anybody really like it when their patients cry? Anybody really like it when you can't avoid crying? When there's a tear in your eye? When there's some choking in your voice? And folks, that's okay when that happens, as long as you don't become the center of attention. If you start wailing, you know, that's not good, okay? Then you're becoming the center of attention. But boy, if you shed a genuine, empathetic tear with somebody who's hurting, that's precious, folks. It's not something you should be thinking about, I'll never do that. I don't want to destroy hope anymore. Common theme. We talked about false hope. It's real, isn't it? Insurance companies don't pay me to talk. I don't have time to talk. I've got some productivity standards I've got to meet. My RVUs are low this month. I've got to see the next patient. And you know what happens if you do have the talk? It opens up all kinds of other talks you need to have. Okay? Talking's really important here. But it opens up the artificial hydration nutrition issues that you're going to have to deal with at some point. There's the DNR orders that you might want to talk about. Should we turn off that implanted defibrillator at some point? And then there's the really ugly word at the bottom of the list. What about hospice at some point? Now, this evolves over time, and not all of these conversations have to be had at the very first time you talk to your patient about having a terminal disease. Some of those patients don't have a prognosis for life of 6 months and would not qualify for hospice services at that point. But thinking about palliative care and beginning to talk through with this family the decisions that are going to come up is really, really important. So how do we respond to the emotional reactions that our patients have? Sometimes they're so overwhelmed and their emotional reaction is so intense, the right thing to do is just to pause and to wait for a while. And maybe even leave the room for a minute. Let them regain their composure and then come back in and talk to them again. Some patients' emotional reaction is going to cause them to deny. This can't be. It's got to be somebody else's lab work. I had no idea how strong this denial thing was. And until October the 11th, 2005 at 10:30 in the evening. I was in bed. My wife was upstairs. She had not come to bed yet. We both pick up the phone when it rings at the same time. And on the other end, there's a sobbing voice, and it's the voice of our daughter-in-law. And she's saying, "Nani," that's Grandma, and Granddaddy, I need you to come and take me to the hospital. She can hardly say this. She's crying. Matthew just died in a car crash. And Matthew was her husband. Matthew's our son. And I heard those words clearly enough that they are etched in my brain. And I was able to say them to you word for word right now. I heard them. But do you know what I said? I said, "Denise, what did you say?" And put her through having to say this again. We'll be there as quick as we can get there. And we're quickly pulling our clothes on and walking out of the car. And I'm saying to my wife, honey, don't worry, this is some mistake. Can't be Matthew. Be better off if it was your child. I mean, or somebody else's child, but not mine. Okay? Denial was really, really, really strong. And there were elements of that went on for a long time. Denial is very, very strong emotional reaction. Anger, you should have found this. The last doc should have found this. Glad I got to you. Numbness, I don't know what to say. I'm just so numb. And crying. And sometimes the most important thing you can do is to sit and listen and listen. Offer an appropriate touch and let them work through their emotional reactions. So those are some of the barriers, some of the things that make it difficult for us to do this. What are some talking tools that you might think about grabbing onto that would help you the next time you're called upon to talk to a family? You got to know the facts, okay? Know that chart well. Know the test results well. Know what this patient has gone through to this point as well as you can before you go in there. know the facts. We need to acknowledge our limitation as doctors. We are not omnipotent. We're not omniscient. We have limitations. And medical science in general has limitations. And we need to acknowledge that in our head before we go to talk to somebody about the fact that they're dying of a disease. Now, American television and American culture denies this loudly. Most of you probably don't have time to watch much TV, and I don't watch much. But if you turn it on between 7 in the evening and 10 in the evening, I guarantee you, you're going to see at least 6 or 10 ads about if you just get your doctor to prescribe the right cholesterol-lowering agent, the right antihypertensive, the right cancer center. If you just send me to Cancer Center X, you know, my chances of immortality have greatly increased. But you know what? It's not true. All of us are going to die. Anybody here that was never born? You know, there's not anybody here that's not going to die. It is going to happen. And we're going to die one of 4 different ways, and you've probably seen this before. You know, this is the patient who has a sudden cardiac arrhythmia. This is a patient who ruptures an aneurysm. This is a patient who has a car accident, and his life is taken out immediately. This is a patient with a fairly predictable terminal illness. Now, Dr. LaPera is here, and she knows that I don't want to say to anybody that if you get cancer, you're going to die, okay? But some cancer patients are going to have terminal illnesses. Some patients are going to die. And this is the model for those who do have a life-ending kind of cancer. This is the model for somebody with ALS. It's a fairly predictable course, and it's a fairly short course from the time that it's diagnosed to the time of death, compared to other chronic illnesses. And this is a quadrant that is growing, folks, and it's growing because we're doing so well at treating chronic illnesses. And what we're doing is that we're extending it out this way, but the slope is still in this direction. We're not curing chronic illnesses, and it's marked by multiple exacerbations, with each exacerbation recovering but never quite getting back up to baseline again. And they get down here and they have that final exacerbation, and we had an example of that this week where a patient's family has been watching this, but they recover. They have this final event in the hospital. They often end up at the hospice house, and the family's saying, "This is so sudden." They were doing well. They were in the hospital 3 times this year, but they came home and they survived. And they look at this as sudden death. And so this one is growing a lot. And I think we're going to see a lot more emphasis on palliative care with this group of people in the future as a part of treating their diseases. And then finally, most of us in this room will die in this quadrant. That's where most people die. It's our patients who just wear out. It's our patients with dementia that go on and on and on, and they just hug that line, and they don't die. So that's the way it really looks, okay? The American dream that I alluded to a while ago, the American dream says that it's just going to get better and better and better and better. And if you take the right pills, it can be really good, okay? But That's not the reality. The reality is that there are limitations that we have as docs. There are limitations that we have as medical scientists. And other talking tools include the fact that we need to initiate this conversation as early as possible with our patients. And we need to initiate it as something we do with all our patients. I'm going to have a conversation with all my patients about end-of-life kinds of issues. And we need to start this conversation as soon as possible. Some other talking tools, you can learn a lot and you can teach a lot by just asking questions. For the patient who doesn't know, the family says they don't know they have cancer, one of the things that I try to do is get the patient to spill the beans for me in front of everybody. Okay? Well, it's good to meet you, Ms. Johnson. My name's Dean Patton, and I'm a family doctor. I specialize in hospice and palliative care. And what's going on with you? What have your doctors told you about what's going on with you? What do you think's happening? So how's all this going to end up? Is a way of talking. What's the thing about being here that frightens you the most? And if they say that dying is what frightens them the most, what is it about dying that frightens you the most? And I get answers that fall into three pretty distinct buckets when I ask people what they're afraid of. And there's one bucket, usually women, not always, but usually women, younger women, dealt with it yesterday. I'm so scared for my kids. What's going to happen to them after I die? My family is held together by me. I'm the glue. What's going to happen to my family when they die? And that's what they're most afraid of, about dying. The second group is afraid about the process of dying. I've never died before. Is it going to hurt? I've heard that it feels like you're drowning. I've heard that it's very frightening. And I can reassure from medical science that we can keep them comfortable during the dying process. And then the other one is spiritual issues. I'm afraid I'm going to go to hell. I'm afraid I'm not going to go to heaven. And those are the three buckets about fear that I see with my patients. Ask them how the news makes them feel, cause them to be afraid, and practice your 7th grade vocabulary, folks. This is not a time to pull out Stedman's dictionary of medical language, okay? This is the time to get back to your 7th grade education and use those kinds of words to talk with your families. I would encourage you to think right now, if my husband, if my child, if my mom had a terminal illness and I needed somebody to talk to them, who comes to your mind right now as the person you would want to talk to them? Think about it a minute. And think about the kind of language you would want them to think about using. What would you want them to say to your loved ones? And then begin to emulate that and talk to that person the same way you would want talk to your patient, the same way you would want that person to talk to your loved one. It's important for us to not be too pessimistic. It's important for us to not be overly optimistic. It's important for us to tell the truth, to tell the whole truth. And then I will ask the patient, or if they're not competent to be able to repeat, what is it you heard me say? It's a great way for me to check my communication skills. And it's also a great way for me to check in on the denial process that's going on. What have they heard, and what do I need to repeat? And this third one, or the second one, about asking your staff for feedback, I've got a lady in my life whose name is Angelina. Angelina's a social worker, and she and I do this together a lot. And it is not unusual for us to debrief after a session with a family. And for me to say, Angelina, I didn't feel good about this piece. What did you hear me say? How might I have said that better? And that's been very beneficial to me. And be prepared to do this over and over and over again for a while as you work through this with your families, with your patients. Now, there's some words that you need to avoid at all costs. I can't care for you anymore. Now, what you're saying is you need another kind of specialist to help you work through this. I need to transfer your care to somebody else. But what the patient may hear is, I don't care for you anymore. So those are some words to avoid. There's no more hope. Hospice and palliative care is about shifting hope. It's about shifting hope away from cure and living to be 100 to a more realistic hope of how do I stay comfortable? How do I meet my family's needs until that time that I do die? Shifting hope. The other one is it's time for us to stop treatment. If that's all you say, it means that there's no pain medicine. It means there's no medicine for anxiety. It means there are no palliative treatments at all. And so those are words to avoid. And the other one is there's nothing left for us to do. You know, even if I just reach out and put my hand on his shoulder, there's something else that I can do to show that I care. Do not shy away from giving advice. Okay? Some of your patients are going to say, what would you do? What would you do if this was your mom? What would you do if this was your dad? And it's okay to give advice. Let me just encourage you, make sure your advice is always in the best interest of the patient. We all have conflicts of interest. I had to make a declaration before I could come and give your grand rounds. I had to declare whether I had any conflicts of interest about what I'm telling you today. If I did, if I had conflict of interest, I would have to explain how I'm going to handle that conflict of interest, how I'm going to manage it, okay? And all of us have conflicts of interest. Sometimes they're economic. This is from JAMA, November of 2011, almost 18,000 patients. This is reviewing Medicare records. This is about imaging after coronary revascularization. Guidelines say the symptoms go away. You don't need to re-image. Okay? So, who got re-imaged after post-vascularization? Okay? Now, the docs who simply ordered the test and no billing for the test, the odds ratio there is 1, okay? That's our control group, okay? But in nuclear imaging, if the doc read the test, didn't own the imaging equipment, the odds ratio was 1.6 for getting an imaging study. And if there was some financial interest in the imaging equipment itself, more reimbursement, then the odds ratios went up to 2.3. If you look at echo, 7.1, 12.8, that's a less expensive test. But the same principle evolved. Now, in case it looks like I'm picking on oncologists and cardiologists today, let me open my heart to you, okay? You know that I started out in surgery from the introduction that I got this morning. One of my favorite pieces of surgery was plastic surgery. As a family doc, I have learned and honed some skills and some flaps and plasties and can do them quite well. So you come in with a little ditzel above your eyebrow. Looks like a basal cell carcinoma. I want to excise that. Simplest thing to do is just a small elliptical incision. Take it out, send it to the pathologist. Diagnosis and cure all at the same time. But you know, that might just tint that eyebrow up just a little bit. And that might make you look a little surprised on that one side of your face as compared to the other side. And you know, I could do an O to Z plasty there. And guess what? I can charge 4 times more and be reimbursed 4 times more for that O to Z than a simple elliptical incision. I say that to say we all have conflicts of interest when we give advice. Make sure that that advice is in the best interest of our patient, not our own interest. Now, some ways to show that you love, you care for the patient, some empathy tools. This conversation needs to be held in privacy. You need to have uninterrupted time. Fortunately, I remembered to turn off my phone. It's been buzzing. I'm anxious to see what it is. I've been a little distracted by what's going on in my pocket here, but need to have uninterrupted time. If multiple family members are present, if you can sit in a way around a table or in a circle in some way that everybody can see each other, it's good, but you align yourself clearly with that patient and that patient's significant other who's there with them. And be in touching distance, so that you can reach out and you can offer an arm, you can offer a hand to appropriately touch and say, I care for you. This is a simple little thing. Let the tears flow for a few seconds. It's okay to acknowledge them. In fact, I'll acknowledge them by saying, you know, it is really special to me, precious to me, that you're willing to share your tears with me today. You know, there's a psalm that says that God considers our tears to be so precious, He keeps them in a bottle. Here's some tissue. Maybe that'll help you feel better. But if I just simply, you know, as soon as I see this tear, I start looking around for my box and I hand it to the patient. One of the things I don't want to communicate is dry up. You're a big boy now, and there's no need for crying. We're going to get through this. I don't want to communicate that, okay? So let the tears flow for just a little bit. It's okay to acknowledge them, and then offer a tissue. Allow for silence. If silence persists for more than 30 seconds, I'm not going to wait 30 seconds, but I'll wait 10. Now multiply that by 3. Wait. Be patient. And if I don't hear anything after a prolonged time of waiting, then I might say, well, I'd really like to know what's going through your mind right now. What are you thinking about? And offer to allow the family to talk amongst themselves for a while and then come back and check up with them. Moody Blues said it this way. And we've been thinking together this morning, okay? I've been thinking the way people do about things that matter to me and you. I've decided to do what I can to find out the kind of man I really am. I've done a lot of introspection about this. I can see the world from here. And folks, some of the things that I see makes me just want to disappear. It's awful. It's hard. Back to nature. That's where we're all going. That's where we belong. Just one truth I found: you can't go wrong. Wherever you go, whatever you do, whatever you say it with love. The Apostle Paul said, speak the truth in love. So in summary, candor is communicating the whole truth with a heart that is sensitive to how that news is going to affect the patient. You need to identify and work through the barriers that make it hard for you to talk about death and dying. I'd encourage you to give this some thought. And finally, practice communicating clearly, completely, and compassionately. Now, I'm going to take some questions in just a minute. But I also want to tell you about some things that are about to change about hospice and palliative care. And I'll take just a minute to do that. We've had a wonderful palliative care consult service here for years. Headed up primarily by a hero in the field, a female hero. Sounds wrong to say heroine, but Susan Redding. And that team has provided thousands of consults for you about patients who are dying and patients who have chronic illnesses that need palliative care. We are going to, we're hiring 3 more FNPs, and one of those, or nurse practitioners, one of those is sitting in the back today who's joined our team. And this team is going to become a very integrated team, and it's going to involve the medical director in some ways that he hasn't been involved before. And I'm going to be seeing some of those patients with this team in the hospital and be involved in some of those consults. The hospice house is going to be much more nurse practitioner driven in the care that's given there, and it's going to be much more continuity by doing it that way. And finally, well, it's not finally, the third thing is, there is a fourth thing. Third thing is that hopefully in January, no later than March 1st, we will be providing a palliative care receiving service in the palliative care unit. So that if you have a patient on the floor that you would like to transfer to the palliative care unit, and if you're one of those docs who doesn't like to walk that far, no, if there's some reason why you would like the palliative care receiving service to care for that patient while they're there, it's not going to become a closed unit. You can still send your patients down there and still care for them. But if we can assist you in that care, if we can provide that care instead of you or in collaboration with you, then we hope that that will provide a strong and good palliative care service for Vidant Medical Center. Number 4 on the list is still on the drawing board, and that's for us to have palliative care consults available in the various clinics on an outpatient basis, so that you could say to your patient, next time we come back, I'm going to bring you on a day when the palliative care specialist is going to be here, and we want them to begin to talk with you about some of the things they might be able to offer in terms of helping you get through this. Okay? So those are some things on the drawing board. Questions? Comments? Dr. Esker. What do you do when they say don't tell them she's dying? Okay, the one thing I'll do is try to get the patient to spill the beans. We've already talked about that. Give lots of opportunities for the patient to say what they already know. I mean, why else are there 20 people in the room whispering in the dark? Okay, something bad is going on. Okay, and most people can put that together. But if all those things don't work, what I will say to the patient near the end of the conversation is, after I've examined them, you know, sometimes family members like to talk to the doctor outside the room, and I don't know whether your family wants to do that or not. I know they do. would it be okay if I took them and sat down in a conference room and answered their questions and see what they want to talk about? And I've never had anybody say, no, don't do that, okay? And if they say yes, then I will invite them to the conference room, and I will sit down with them. I'll ask, why is it you don't want them to know? What makes you think they don't know? I really believe they have a right to know. And let me rehearse for you the conversation I want to have with Grandma, okay? And, I will just go through the conversation that I want to have with Grandma, so that they won't be surprised. And I say, this is what I want to do. And if they say that's okay, that's great. I've only had one patient after that, one family after that conversation say, no, it's not time, I can't let you do this. And I've respected that, and after about 3 days, she's saying, yes, you need to tell. And it's a by that point, they've had all this supportive care of our hospice staff. Folks, we've got a wonderful, wonderful, wonderful staff over there. If you've never been there, come. It's not a sad, morbid place, okay? You're going to hear singing in some rooms. You're going to hear laughter in some rooms. You're going to hear crying. But it's a fantastic place to work. It's a fantastic place for your patients to be. Pardon? Oh, there is lots of food. People bring in food all the time. Yeah. Dr. LaPera. Thank you. Right. I love what you've just said. And I sometimes say it a little bit differently, but I think you and I are giving the same message. And when they get to the hospice house, I tell them that we specialize in caring for people, not diseases. And in fact, we don't treat diseases at the hospice house. And I would like to look at the hospice house as an intensive care unit. And they're going to be cared for there intensively. Thank you so much. Anything else? Thank you all a bunch. Hope you all have a great day. Go and do good things.